So the topic is principles of skull-base surgery for brain tumors. And as most of you know, this is a textbook and for many people, several-year fellowship. And so it's impossible to condense it down into a 40-minute lecture. But I just wanted to go over some of the basic principles and start from there. First, I have no disclosures that are relevant to this talk. One of the questions is, what is skull-base surgery? What is this different from other types of tumor removal surgeries? And as I think most of you know, that the main premise of skull-base surgery is to remove the skull-base bone to get access to whatever lesion you're trying to get to and avoid retraction of the brain. And that was actually the main impetus of skull-base surgery. If you weren't removing the skull base, you're having to do a significant amount of brain retraction to get deep within the brain structures. But in doing this, you want to maintain cranial nerve function. You want to preserve the cerebral circulation. And obviously, in the end, you're trying to do the best tumor surgery that you can. The way this talk is organized is into sort of 4 sections. There's patient selection, operative planning, a little bit about surgical technique. That's really learned in the operating room, and complication avoidance. So I'm going to start off with just a very short case here. We have an asymptomatic patient who was found to have this lesion. Obviously, it looks like a meningioma involving the planum sphenoidale. And so in seeing this patient, one of the things as a resident, you often see all the great operations that we do here, but what you don't see is on the outpatient side, what do you do with this patient that perhaps doesn't make it to the operating room, and how do you make decisions regarding any given case? You want to look at, you want to factor in things like how certain are you of the diagnosis. I think most radiologists would just say that this is a meningioma and unlikely anything else. In discussing with the patient, you're trying to be the crystal ball of gauging, well, what's the potential tumor growth? What structures are it next to? If it does grow, is it going to be a problem? And you have to take into other factors. So just to give you a background of what kind of information that you have to have at hand in the clinic and part of your education is incidental meningiomas. Turns out that 30% of meningiomas are incidental. But the same thing happens for aneurysms and all that. When you see something that's an incidental finding and more MRI scans are being done for other reasons, we see more and more incidental findings. It turns out that people have looked into this, and for incidental meningiomas, tumor progression occurs in only, in 10 to 20% of these patients. So you can't look at the patient and say, oh, your tumor is going to grow, because actually these statistics are against you. Most of these tumors actually are quite stable. And if you look at segregating calcified versus non-calcified meningiomas, it turns out that the calcified meningiomas almost never grow. At least this is what's been reported in the literature. So these are all factors that you have to take into account when you're counseling the patient about what to do. But for the ones that do grow, they do grow, and it turns out that even elderly patients, they grow 1 to 2 millimeters per year. So if you're looking at patient selection and what to do, one of the options is always going to be conservative management. And 20 or 30 years ago, this used to be a real issue of how exactly do you manage someone with conservative management? Do you wait till they become symptomatic? But this machine here has radically changed that now. Unless the patient is unable to get follow-up MRI scans, you can really, I think, safely follow most patients. And you have to explain to patients that often these tumors don't grow more than a millimeter per year, and the resolution of judging growth is about a millimeter per year for MRI scans, and it may take 1 or 2 years to actually find out what their growth rate is. But when you're doing serial imaging, you're doing more than just assessing the growth of the tumor. You're looking for associated issues such as hydrocephalus. And at the same time, you need to counsel the patient to monitor other issues. If the lesion's near the optic chiasm or the optic nerve, they need to have serial visual testing, perhaps auditory testing for acoustic tumors. For lesions that I deal with, we monitor their pituitary function. And for example, if they have a frontal meningioma, you may want to have some type of monitoring of any psychiatric symptoms such as depression. One of the major game changers, obviously, for skull-based surgery has been stereotactic radiosurgery, the Gamma Knife, the CyberKnife, Novalis systems. And again, you really have to understand what the utility, what the indications for these procedures are, and also to understand the different types of procedures. I see patients who have 3-centimeter lesions who were told that this lesion is too big for Gamma Knife, or it's too big for radiosurgery, and therefore they have to have surgery. And it turns out that that's actually no longer true with stereotactic radiotherapy methods, that larger tumors can be safely irradiated. I think one of the best courses I ever took with regards to training to do skull base is actually the radiosurgery course here that we had. It's a 5-day course. And I think it's so important that for any skull-based surgeon, that you really have to have a thorough understanding of the indications, outcomes, and complications of radiosurgery, or you really shouldn't be doing this. And actually, most skull-based surgeons do radiosurgery as well and offer that on both sides, so they have the complete armamentarium. But this is so important, and it's not necessarily even an either-or situation of, well, do they have surgery or do they have radiosurgery? More and more often, it's both. There's roles of surgery, perhaps to prepare the patient for radiosurgery. But this is a talk about surgery and about the surgical management option. And I've heard this from many different speakers, but when you're speaking to a patient about surgery, I think it's very good to really stop and think, would I recommend surgery if this was me sitting there across from me, or my father, or my mother, or my daughter? And it really makes you stop and think, wow, am I making the correct recommendation here? Because it's a very serious recommendation, and it sort of helps you gauge other factors that you may be factoring in your decision. And in making this decision for surgery, one of the issues is what is the goal of surgery? And I think it's important to explain to patients what is it that you're trying to achieve with surgery. And this is sort of the list that I go down with the patient every single time, whether it's a skull-based tumor or even a glioma or another lesion. First is just to make a diagnosis. Again, for meningiomas and sometimes for acoustic neuromas, there's not a lot of question in terms of the imaging of what it is. But for many other lesions, it is. And particularly when it comes to whether the patient gets radiation or not, many radiation oncologists will not irradiate many lesions without tissue diagnosis. So at a minimum, that's something just to address of obtaining a tissue diagnosis. Of course, when we do surgery and we're going to go in there other than a needle biopsy, then you will obviously consider cytoreduction. And what exactly are you trying to achieve with cytoreduction? If the patient has mass effect, if their brainstem is being distorted and compressed, obviously one of the goals is to decompress the brainstem to improve function of the patient. You want to decompress cranial nerves. The classic one is the optic nerve, the optic chiasm, patients losing their vision. That's not a good case for radiosurgery up front. You want to decompress, improve their visual function, protect it, and then perhaps have other treatment. As I mentioned, sometimes you can actually improve the radiosurgery target by making the lesion smaller or taking it away from an important structure such as an important cranial nerve, the pituitary stalk, the brainstem. And then in other cases, if you have a patient that has documented tumor growth, even though they are asymptomatic, you can just connect the dots, extrapolate, and figure that they will become symptomatic, and therefore you're doing preventative surgery so they don't become symptomatic in the end. I put the last one as last for a purpose in that it's not always you're trying to get the surgical cure, because this goal here is often what results in more complications than anything else. And for some patients, it's very important for that particular case to try to get a complete gross total resection. But in other cases, you really have to stop and think about it, and it's definitely not the goal for all patients with skull-base surgery. So when it comes to patient selection, who is a good candidate for surgery is another issue. You can have two identical looking tumors, identical size, but if you have perhaps a 90-year-old patient such as this, perhaps surgery is not the best option for an older patient, or a patient that has significant medical comorbidities. If they've had a myocardial infarction in the past, they have significant peripheral vascular disease, they're on Coumadin, they have to be on some type of anticoagulant or antiplatelet because they have a valve replacement in their heart. You kind of have to look at all these different factors and decide, is this the appropriate patient to recommend surgery for? I think even more difficult than that decision of trying to understand, is this the appropriate patient, is that you have to decide whether you're the appropriate doctor to do the operation. Do you have the surgical experience? There's so many studies that show that high volume surgeons, if you do over 50 cases of the same type of case, that your outcomes tend to be better than those who see one or two a year. Can you offer all the different types of procedures that perhaps, endoscopy is not the right procedure necessarily for all skull-based tumors, but it may be for certain skull-based tumors. And if you can't offer the right technique, or if you don't have that experience, I think it's always a good idea to refer to your colleague, or to perhaps even another institution where someone does have that specific expertise for that certain type of tumor or location. And then you have to look at other factors such as where you work. Skull-based tumors are difficult tumors, and the complication rate, because you're dealing with sometimes large vascular structures, cranial nerves, results that your patients often need a higher acuity of care after surgery. And if you're in a solo community practice at a hospital that maybe has an ICU that's not staffed by neurosurgical nurses, it may not be the right place for a high complexity skull-based tumor. Although you may be a fantastic surgeon, the location that you work may not be the best place for that. I certainly don't take for granted neurosurgery residents, because the residents are like the 24-hour in-house way to monitor patients, which is, I think, highly critical and helps the patient recovery. And I mentioned before, neurointensive care management, neurointensive care nurses who understand how to do a neurologic exam, and the importance of managing blood pressure and these different issues. And lastly, do you have all the ancillary departments to do preoperative embolization? Or if there is a vascular incident that occurs with surgery, can the patient go immediately to the interventional radiology suite to be coiled or have other rescue techniques? So these are all things that you have to factor in making a decision of what's the best thing for your patient. So in terms of operative planning, this is probably the biggest part of the talk, because for skull-based surgery, it's probably the most important part of what you do before surgery is so much, it's critical to the success of the surgery. Skull-based surgery is really a surgery of the planning of angles and looking at the exposures, and it's really 3D anatomy, trying to picture something that's deep inside the brain, how you're going to get there, and understanding all the relationships of the major arteries, the cranial nerves, the skull, the muscles, all these different issues of trying to figure out how you can get there safely, effectively, and there's, this talk is really on the shoulders of a lot of great pioneers who've done this amazing work of developing these different approaches. Many of them have come and gone. A lot of approaches to the cavernous sinus, are really done by very few people because even though they're very elegant approaches, the morbidity associated with those approaches was too high. But this can't be overstated, that you really have to study and understand the anatomy and the 3D anatomy, particularly the skull base and the cranial nerves and the vasculature, and understand these normal relationships between the two, and then you can then apply this to the pathological conditions. And I learned from the neuroradiologist, if you determine where the epicenter of the tumor was, you can actually then sort of figure out where the normal structures became displaced, and this is how you figure out the relative anatomy. But you have to know the normal anatomy first. So in this particular case of a craniopharyngioma, the first question always is, where is the optic chiasm? Is the tumor behind the optic chiasm? Is it in front of the optic chiasm? And by knowing some basic anatomical relationship that the anterior communicating artery is almost always associated with the chiasm, if you can find the anterior communicating artery, then you can then localize where the optic chiasm is and see where it is relative to the tumor, and then gauge your approach based on that. One of the major issues with skull-base surgery are the major cerebral vessels, and particularly the internal carotid artery, because it's running through the skull base and surrounds many of the deep structures. This is a view from an endoscopic case in which it's quite a remarkable view, that this is the clival segment, the siphon, and then actually we could even follow it intracranially. You can see how it could be completely dissected out. The sella is down here, just to give you an idea of the skull base anatomy. But the issue here is that in general the carotid artery cannot be moved. You cannot just swing it to the side and dissect behind the carotid artery. Your approach has to be tailored to take into account these major cerebral vessels and how you're going to get around them, or at least safely manage them if they're involved. Particularly for the endonasal endoscopic approach, the carotid arteries make up the lateral aspect of your approach, and they're sort of the pillars that the room that you're entering, and to go beyond them, which you can do with some trepidation, but usually those are the areas that you have to say, well, I can access things between the carotid arteries and perhaps a little bit around them, but not too far. It's obvious and it should be intuitive that it's not just the major vessels, but you also have to preserve perforators. And the real trick to that is to avoid blind dissection. You really want to be able to visualize and see what you're doing. If you're passing instruments blindly behind vessels where you know that there are perforators, the chances of complications go much higher. Then lastly, in your planning, and this is all about planning, you have to have an exit plan of what happens in certain scenarios, and you kind of, if you're dealing with a tumor that is involving the internal carotid artery on one side, you have to think beforehand, what are you going to do if there is an incident in the operating room where you have carotid bleeding? Can you sacrifice that artery? Have you assessed the circle of Willis? And if it looks a bit dubious, do you then do other preoperative assessments of whether it's imaging or perhaps even test balloon occlusions? Can you sacrifice that artery if necessary? It's more of a situation when you have especially redo surgeries, patients have been previously irradiated and that artery may fall apart. These are all things that are critically that you have to do before surgery, because if it happens during surgery, it's too late if you didn't think about it. More about 3D anatomy principles, and here, we live in an age of multimodality imaging that has really, enhanced this field significantly. In the past, trying to do these procedures based perhaps on a CAT scan and a cerebral angiography alone, or even before CAT scans, I can't imagine trying to approach some of these deep-seated lesions, and I guess by and large they weren't. But now with 3D anatomy that you can get from multimodality imaging, you can get a pretty good idea of certainly where the vasculature is, and many of the major cranial nerves. It's still very difficult to image the very small cranial nerves, fourth nerve, sixth nerve, in most cases. Here's a case of a clival chordoma. You can see here it's eroded intradurally and it's pushing on the pons and involving the upper segment of the clivus. In this particular case, we did want to look at the vasculature, because what was its relationship to both the basilar and the internal carotid arteries, and I sort of drew them out here as well as a sort of rough sketch of where this tumor is. And if you look at these relationships and look on this at least axial CT angiogram image, you can see that different approaches may or may not be ideal based on certain aspects. So if you're trying to come subtemporally and approach this, well, you can see that that internal carotid artery is going to be right in your way between you and your tumor. So that's going to be a major challenge. If you want to come from the posterior fossa, well, the basilar artery is sitting right there, and you're going to have to be working around the basilar artery and all the perforators. And obviously, the best approach here is to come anteriorly, because you basically have the arteries on the side and the basilar artery in the back, and you have a direct approach to this tumor. And this is just an intraoperative image from an endoscopic approach showing the dural opening, and you can see the basilar artery there preserved because we are able to remove it from an anterior approach. In addition to the arteries, the cranial nerves are obviously very important as well. And here, often you don't have as much choice of your approach in terms of what angles of approach, because cranial nerves to some degree can be manipulated, especially the lower cranial nerves. You can dissect them and sweep them aside, so it doesn't have that same criteria as the large major arteries. But in general, a basic principle, it's always good to remove the tumor from the patient rather than the patient from the tumor, and you've heard that before. So if you can have some of these structures on the side or behind and remove the tumor towards you, it's in general much better than having to manipulate and move cranial nerves aside. But for all these approaches, again, you want to find the normal anatomy if you can first, and then be able to trace that and maintain it. You don't want to discover it at the bottom of the tumor resection and discover it after hopefully it hasn't been injured when you found it. So for all these approaches, the exposure that you plan for has to take into account of trying to find the normal anatomy that you're trying to preserve. Probably the best example is the translabyrinthine approach for acoustic neuromas, in which you find the seventh nerve early, and then you try to remove the tumor and maintain the seventh nerve integrity and that's probably the main reason that approach is used. Lastly, whatever approach you use, if you're going to be dissecting around major arteries and cranial nerves, you have to be able to use microdissection bimanual technique. So if you can get to some place, but the hole that you've made is so small that you can only use one instrument and block your view, it's not what you want to be doing for dissecting around cranial nerves. Just to sort of review, you want to be able to access the entire lesion, to see it throughout, preserve function both of the cranial nerves, but also mechanical function of the muscles and other tissues around it. So here's another chordoma patient. This patient, the chordoma is very low. It's actually at the base of the skull, and in between the clivus and the dens. And for this particular operation, you have to look at it from a variety of different aspects of how we're going to approach this here. So looking at these axial T2 imaged MRI scans, chordomas show up high signal intensity on, so I'll kind of point you to what you're looking at here in terms of the lateral aspect and extent of this tumor as we go back and forth. And you can pretty much see right away that any lateral approach here, if you want to do a far lateral approach to this, you would certainly be able to make a tissue diagnosis. But whether you're coming from one side or the other, I don't think you'll be able to reach this side if you approach it from the left side in terms of this extent of tumor here. So these are all the different 3D anatomical relationships that you have to look for any given approach. You will not be able to see the other side if you come from a lateral approach. So here's a reconstruction from a CT angiography looking at sort of the bony anatomy and the relationship of the nose and the mouth with regard to this particular lesion. And here you can't see the lesion well here, but from the MRI you know the lesion is here. And since we know a lateral approach wouldn't be a good approach here, one consideration would be a transoral approach. It's the lesion's right there in the back of the oral pharynx, but when I'm referring to preserving functional ability, now you're going to have to deal with the palate and swallowing abilities afterwards, versus you can also approach the lesion from an endonasal approach. And endonasal approaches now can basically reach all the way to the top third of the dens and up to the frontal sinus here. So we did approach this lesion from an endonasal approach, and this is a 45-degree endoscope looking laterally into that gutter that I was showing. So we've actually emptied out the tumor from both gutters near the condyles. And here's the preoperative image, and you can see that we were able to clear out the tumor on both sides, again, by using this concept of 3D imaging. For whatever approach you choose, then, you also have to consider what are the possible negative effects of the skull base approach. And I personally think that this is perhaps an overused approach in many cases, the modified or the full orbital zygomatic approach, because it really isn't necessary for many tumors, such a lateral sphenoid ring meningioma. You don't need to take off the roof of the orbit. And you kind of have to look at, well, what are the possible complications, including frontalis nerve palsies, supraorbital nerve injury. When you start dealing with the zygoma, you can get trismus afterwards, and swallowing or chewing issues. And I think the worst case scenario is if your bone flap becomes infected, the cosmetic issues could be significant because it's very difficult to reconstruct this anatomy if the bone flap has to be removed. So these are great approaches if used with the appropriate patient, but you don't want to overuse them because there are certainly negative ramifications from that. Then lastly, don't forget that just the real basic issues that you have to think about and make a mental checklist for every single patient. If you're dealing with lesions around the carotid artery or the clivus in which there's significant blood loss, you really have to obviously counsel your patient about autologous blood donation or direct-to-donor blood donation. You have to order the appropriate physiologic monitoring and make sure that if you're using a certain type of monitoring, that you communicate with the anesthesiologist. If you're going to use motor evoked potentials, the type of anesthesia that they're going to use would be different. Order the correct equipment that you're going to need for the operation, and then have realistic counseling with your patient in terms of what type of goals that you have for this operation, that they don't think that you're trying to do a complete curative operation in every case, and for them to understand the possible neurologic deficits. So again, I can't make a lot of comments about surgical technique, but that's something you really need to learn in the operating room. But as this cartoon says, it's very important just to go slow, because you're dealing with a lot of delicate tissues, and to do no harm. And that should be your motto during the operating room. Because I firmly believe that, for many patients, having a new or significant neurologic deficit sometimes is scarier than actually dying of the operation, because they're going to have to live the rest of their lives with these deficits. And that should be in your mind throughout the operation, is not to create a new neurologic deficit. And sort of, I think one of the philosophies here at UCLA hasn't been to go for a total resection in every case, but it's better to do a subtotal resection and have the patient intact than have a perfect MRI scan afterwards with significant neurologic deficits. So, you know, as a simple way, if it's there's a saying that the tumor makes the surgeon, that if it's a soft, easy tumor, that things are going well, and it's easy to remove the tumor, that it's not stuck to cranial nerves or to the arachnoid, you can proceed. But if it's very difficult and you think that you're going to have a neurologic deficit here, it's best to leave some tumor next to the cranial nerve, and then afterwards you can monitor it, or you can perform radiosurgery or stereotactic radiotherapy for that. And lastly, as you're doing these dissections, it's not necessarily the nerve that you have to be thinking of, it's the microvasculature to that nerve and preserving the arachnoid and sweeping the arachnoid off to maintain the function of that nerve. The goals of each operation really has to be individualized based on what the pathology is, whether it's a very benign slow-growing tumor or a more malignant tumor or one that has a high propensity of recurrence, how old the patient is, how aggressive you are may be dramatically different in a 20-year-old patient versus an 80-year-old patient. And also, if they already have a fixed neurologic deficit, you can obviously be much more aggressive in removing a tumor than a patient who's neurologically intact, and you can only make them worse. And as I mentioned now for the third time, the goal of cranial-based surgery is often just to optimize stereotactic radiosurgery or radiotherapy, and to go back during the operation to think about the same list of what your goals were before surgery, and not change that during surgery necessarily. As you're performing the surgery, you really need adequate exposure to do a good job of removing tumors safely, to find the normal anatomy. I use this example here that for skull-based surgery that's approached anteriorly, endonasally, if you use a speculum, the view that you get with a speculum is very narrow. And on the right there, you see a microscopic view through the speculum. But endoscopically, the view that you get is it's more panoramic, and you can find many other structures that are no longer hidden by the confines of the speculum. I'm a fan of a team approach to skull-based surgery for a variety of reasons. One is that you bring added expertise from the outside. Many of the morbidities of skull-based surgery involve actually the skull base, the musculature, hearing, other issues that aren't necessarily the tumor itself. And at this institution and many skull-based programs, head and neck surgery is just a natural synergistic combination of talents to perform these surgeries. For endoscopic surgery, clearly 3 hands and 4 eyes are better than 2, in my opinion. And as I mentioned before, like the healing of the nose, the patients are really cared for best by a rhinologist, not by a neurosurgeon that after these endonasal approaches. And this applies to posterior fossa approaches, orbital tumors with the oculoplastic surgeons. I think the team approach is highly beneficial for the patient. And then lastly, equally important is complication avoidance, and trying to think about not just how to get there, what the anatomy is, about how I'm going to avoid complications. You know, again, it begins with surgical planning. These are things that you have to think of before you do the operation, and have different plans of what you're going to do if certain event A, B, or C occurs. And this old saying, an ounce of prevention is worth a pound of cure. I didn't realize that Benjamin Franklin, it says here, I found this picture that he's a doctor, and I wonder where he trained in using some advanced image analysis. It's amazing. I didn't know he trained at UCLA, so it's great that we've trained some of the best. I'm going to limit this really complication avoidance to closure and reconstruction issues, because sometimes that part of it, you get so involved in how to approach the tumor, how to remove the tumor, that you don't put as much emphasis on how you're going to finish the operation. And this will probably get you into more problems than anything else in terms of reoperations, readmissions, and sometimes patient unhappiness. If you look at the CSF leak rates in the literature, they're quite variable, but they range from 30 to 40%. And this is something that, as a skull-based surgeon, you have to put a lot of mental effort into how you're going to address this up front, first to your plan of how to avoid it, and then second, and perhaps more difficult, is after the end of 14 hours, how you're going to have the fortitude to continue that operation and close it correctly and not try to skimp on the last part and you took the tumor out, you're done, and you leave, because this part here, I think, is an important part. Here's that same craniopharyngioma case that I showed at the beginning, looking into the roof of the third ventricle, and you're obviously going to have a significant CSF leak potential with a case like this. So, again, the operative planning is a critical part. And even where your skin incision is, looking at the vasculature of the musculature, trying to preserve this on the way in, could make a significant difference in terms of the closure of the patient. I think this field, and if you go to the skull-based meetings, half the talks now are about vascularized flaps. And the plastic surgeons have been doing this for difficult wounds for many, many years, and neurosurgery is often late to adopt certain techniques, but certainly for the endoscopic and the nasal approaches, this is what we do routinely for patients in which the CSF leak is of risk. And it really makes sense. If you can have a vascularized living tissue that heals quickly, the chances of a good repair are going to increase. And if you're not aware, the nasal septal flap that was first described by Haddad and someone, I can't pronounce his name, I apologize, but it's based on a vascular pedicle whose blood supply comes off the sphenopalatine artery branches that's taken from the nasal septum, and this pedicle is like a big tongue that gets rotated back to cover a defect. Here's some of the work that we've done here in terms of skull-base repair of the sellar and parasellar region, and it's what we refer to as a dual-phase repair. Whatever repair that you use initially, you want to get a watertight closure, whether you're using a fat graft or something to basically plug the hole. But the problem with using any non-vascularized tissue is that it can break down over time. So you may get an immediate repair, but this patient may come back a week later with a delayed CSF leak because your fat graft basically dissolved, or it didn't heal fast enough because it doesn't have a blood supply associated with it. So I call that the acute phase portion of the closure. And what we've done is, if you have a large defect, again, this is that same craniopharyngioma, if you were to stuff fat into this hole, you could basically recreate the whole mass lesion by stuffing a huge piece of fat to try to occlude this hole. And we've basically developed a method of placing helostat here and anchoring it with wet clips to the dura, basically to create a diaphragm, or almost like a trampoline. And then we put the fat against that and bolster it with a buttress and basically push that fat against our diaphragm there. It keeps the fat from herniating into your surgical resection site, but it creates a watertight seal. And that's the acute phase. And once we have a watertight closure, we then rotate the flap, and here's the fat with the buttress of a piece of bone, and this is the nasal septal flap now rotated over here, and within 48 hours you get excellent healing of this nasal septal flap, and I call it the delayed phase portion to try to prevent the delayed leaks, because you have very good closure with this. Al-Mefti has actually described something similar for posterior fossa, where I think all of us are challenged with CSF closure and reconstruction issues. Basically rotating temporalis muscle down over. It's the same basic principle. You need to get a watertight closure first with fat or whatever you choose initially, but then to rotate a vascularized, pedicularized tissue to then get excellent healing over it to prevent delayed leaks. And then lastly, wound closure. You can do a beautiful operation, but if you place staples in 10 seconds and have wound edges that are not completely opposed, you're going to have a wound breakdown and take a beautiful operation into a complication. And I personally prefer vertical mattress sutures. Again, it's what plastic surgeons do for their closures. It's good, has good strength with a deep layer, and the superficial layer gives you perfect apposition of the skin edges. And the other issue is to avoid traction of the scalp. And I have to say, when I trained, I remember having to, quote, scrunch the skin together, and there'd be one person's job to hold it together while someone sewed really quickly to close it up. And in retrospect, it was the absolutely wrong thing to do. This is not, again, what plastic surgeons do. They'll tell you that if you have a skin that's under tension, it's going to fall apart. And so this is where you have to do release incisions or subgaleal scoring to bring skin incisions so they're now relaxed, and your closure complication rate is going to be significantly less. Lastly, there's always cosmetic considerations. I personally think that the eyebrow approach and the keyhole approach is a good approach, but I have seen patients that have significant cosmetic issues after that, and even though some of them are excellent, when they're bad, they can be quite disfiguring. So in summary, the successful skull-base surgery is really a product of meticulous attention to detail, and you have to define your surgical goals for yourself, for your patient, really do detailed preoperative planning, strike a balance between how aggressive you want to be with the surgical resection, between radical resections or just conservative surgical philosophies, and then again, think about the closure and the methodical execution of your goal. Here's some of the references, and skull-base program I don't think, can ever be one person. I think I'm just privileged to work at an institution where we have such a great team of physicians that allow this kind of work. And want to put a plug in for our new acoustic neuroma surgeon, Isaac Yang, who's heading up with the head and neck surgeons.